I'm Josh Durso, and this is Inside the FLX. The United States Department of Veteran Affairs tracks a lot of data. They estimate that a quarter of all vets in the U.S., or 4.7 million, return from active military careers to reside in rural communities. They choose these communities for a variety of reasons: closer proximity to friends and family, open space for recreation, privacy, lower cost of living, or less crowded communities and schools. However, there are challenges to providing health care, especially when that means mental health care, in these rural communities. The VA says that compared to urban areas, rural communities often have higher poverty rates, feature residents with poorer health, and have fewer physicians, practices, hospitals, and other health delivery resources available. To make matters worse, many of these communities have aging populations. Today we sit down with Dr. Marek, Kopacz, and Kelly Mohrman to discuss research and ways that rural outreach is happening here in upstate New York. It's a fascinating conversation and one that you definitely want to stick around for. That said, if you want to get a different perspective on this conversation, check out the brand new podcast version of the show by visiting www.insidetheflx.com. Doctor, one of the primary drivers behind this conversation, the inspiration for it, moral injury. What is this? So walk us through what moral injury is, first and foremost.
Thank you for that. Moral injury, it's a very up-and-coming topic, showing up in quite a few studies, conversations, lots of veteran groups, families. They use the term that we're suffering from, we've experienced moral injury. And so it's really important to get a good handle on what that really means. Moral injury, it implies that somebody has done or seen, so they can have an active or passive role in an event that's described as morally injurious. Basically, that translates into that there's a huge disconnect between what happened and what should have happened. And that disconnect between those two halves, it carries a lot of weight, and that weight is problematic. That weight is what causes mental health problems for a lot of veterans. It's a source and a cause for suffering, and it's very problematic. And I can say with great pride that the VA is really working in leaps and bounds to find supportive strategies, options for bridging that disconnect between what happened and what should have happened, mitigating that weight, taking that weight off the veteran's shoulders so that they can go on to lead productive lives, free of that burden.
So what do we know about moral injury now that perhaps we didn't in the months or the years leading up to that term sort of becoming a little more mainstream?
So moral injury, as far as the narrative goes, really essentially is nothing new. Moral injury has existed since time immemorial, since the beginning of armed conflict. And within those armed conflicts, you have ethical problems, ethical dilemmas. You have to make incredible, difficult decisions, spur of the moment. You don't have the benefit of thought processes. You can't think it out. You can't rationalize. You have to act. And so the idea of moral injury has been around forever, but it was only until around the mid-90s that the term was really cemented. And it was cemented by a gentleman named Jonathan Shea, a mental health provider. And he really anchored the concept of moral injury in ancient Greek texts, just to illustrate, if anything, how far back it goes. And since that time, we have taken moral injury and applied clinical standards. What does this change for the veteran, for their clinical trajectory? How does this impact their health, their well-being, their quality of life, living? And we're really understanding more and more with each passing day the implications of that moral injury, that it really hurts the veteran more than just at a existential level, but there are very specific boots on the ground clinical implications, stuff that happens in the life of the veteran impacting their health. And it really adds to the urgency of how and why we need to continue the work we do and help veterans to the best of our ability.
And what's happening now that maybe wasn't happening a few years ago in terms of trying to better understand? Obviously, you are a researcher, so I would imagine there's probably some research happening right now. What's happening now that wasn't happening a few years ago?
I take great pride in saying that in collaboration with some colleagues, we have undertaken quite a few studies to really get to the heart of what is the root cause of moral injury. Where does it begin? And so what is that process that takes a veteran from a morally injurious experience to this clinical state of moral injury, that they're morally injured? What is that process? If we understand that process a little better, then we can apply very specific interventions, stuff to keep that process from taking the veteran to a state of moral injury. We can apply supportive strategies. We can help that veteran connect those two halves between what happened and what should have happened. So that's one novelty that's been coming up in recent years. Another one is very specific manualized clinical interventions, stuff that is becoming more and more available not just at VA medical centers, but at other mental health care facilities throughout the country, that mental health care providers are learning about strategies such as adaptive disclosure, it's called. These are therapies, manualized interventions with evidence-based to show that if a veteran who is experiencing moral injury participates in this clinical intervention, that they can connect those two halves a little better, bridge that disconnect between what happened and what should have happened. They can process the experience. Their symptoms might decrease. These studies of these clinical interventions are showing very, very favorable, very positive results. So, we have a greater understanding of the problem, what I referred to earlier, and we have a growing number of services and concrete evidence-based options that we can offer veterans who might be morally injured, that we can help them get better, get on with their lives. And from a purely research perspective, what we also have are a growing number of validated tools, stuff that we can use that is past muster to better understand the problem. So surveys, interview scripts, stuff that we can ask the veteran, did you experience ABC or XYZ? And we can objectively start to measure that experience of moral injury that veterans are experiencing. For example, killing in combat is frequently cited. How killing in combat impacts the veteran's life, their health outcomes. And so, with those concrete, objective numbers, facts, figures, we can apply that to the research programs, to developing supportive strategies, to understanding the core of the issue. So VA really is on the forefront of that initiative, so we're really proud of that.
And Kelly, when we talk about obviously being on the ground with this issue and working with people directly, vets directly, what are some of the things that you guys see in practice that give you a little bit of hope about the progress that is being made, not only on the research side, but also how that research is being applied and used?
Well, I think, part of it is trying to get veterans into the VA. We know that of our 20 veterans a day that are taking their lives, only 16 are not connected to VA care. So we're trying to get in more and more veterans. The research that Marek talked about is proving that veterans that come into VA care have a much greater chance of living happier, healthier, more productive lives. They're with their peers. They're with other veterans, irregardless of the era that they served, that have been through similar or exact, or almost exact experiences. So they know that they're not alone. They have that sense of camaraderie again. So I think that's one of the big things is just trying to get more and more veterans in. We are certainly always working to decrease that suicide rate. We would love to have it at zero. There's a huge thing out there for the Zero Initiative. I would love to see that happen in my lifetime. That's one of the big things. The other thing is that in working with some veterans that have had maybe a suicide attempt or have chronic suicidal ideations, I have heard about their experiences with, this combat or harming innocent people who we thought were coming after us. Really is that disconnect, like Marek was talking about, with what I believe in my faith and my morals and what I was brought up to know. And seeing them come in and work with therapists through whatever different evidence-based practice they're going through, and with peer groups, and just talking and being able to freely talk about those things with someone that understands is amazing. I mean, just to show the growth that they go through.
And I'm curious, both your perspective on this actually, the challenge or the difficulty trying to identify that the place where perhaps the moral injury occurred, and what that looks like in sort of the interaction that a clinical worker might have with a vet, and how that's, or what that process looks like.
As far as
when you're going actually identifying, is there an effort to identify where that stressor occurred that brought on the various mental health problems that followed, or is it more or less trying to unpack and work through the results?
I think it's trying to unpack, and correct me if I'm wrong, but
Please.
We always talk about it with the veterans like it's kind of peeling the layers of the onion off. Mm-hmm. You have this big initial overarching thing, but when you start to get down to each layer, you finally can peel it away to get to the core. So sometimes there's like immediate things that need to be dealt with. Maybe homelessness, maybe unemployment, maybe the mental health, getting on medications, getting into therapy. And then as you go in a little deeper and they develop that trust and that working relationship with their therapists, I think that is able to unpack a little bit more as we go on. And then there may be some of those things with moral injury down deep in there and where it occurred. Sometimes vets don't want to talk about those things right away. I mean, I'm just, meeting you for the first time. I'm not going to come in and go, oh, hey, I had this horrible experience that happened. No, we need to develop that trust and be able to work to get to the core of that and know that you're going to work with me and you're going to be there with me through the whole process.
So it is like working backwards. You start at present day and you slowly kind of work your way back?
I would say it's kind of the oxymoron to have it happen the other way, where someone just comes in and spews it all out at once. It does happen. Mm-hmm. Not everybody's the same. So,
well, does that change? So my curiosity would be, does that change sort of the follow-up, or what happens next? Or is it still, even if they do spill everything on day one, you still go all the way back to where you are present day and sort of work your way backwards to that event, even though you already know what that thing was?
Yeah, because you have to work through it and learn how to process it so that so that you can go on and continue to do the work to move forward from there. Mm-hmm. You may come out and just spill it all out, but it's still there. Right. You haven't processed through it at all. You haven't worked it so that you can come to terms with it in your own mind and be able to live and move forward from there. So,
building on what Kelly mentioned, the difficulty, the challenge of suicide prevention is that very rarely is it about one thing.
Right.
Very rarely is it just one singular risk factor that if we fix this problem, then the individual should be fine. It's a very complicated interplay of how the pieces come together, or in some cases how the pieces don't fit together. And with that being said, a general approach is we start by addressing those most imminent risk factors. What's the most problematic thing for the veteran at that precise moment? What is causing his or her distress or crisis at that moment that we're interacting with him or her? And once we get past that point, once we bring the veteran to some basic measure of stability, then, as Kelly rightfully mentioned, you start peeling away the layers. So using the example of homelessness, if we bring the veteran to a safe shelter, a safe environment. If we remedy that problem of homelessness, if only in the short term, then we can start asking the question, what brought you to this point? Why are you homeless? What has happened in your life? And then we can start hearing stories about substance abuse, about family difficulties, about mental health issues. And the great news there is we can help you with that. And so we're peeling away those layers, and we're getting past all the problems, all the difficulties, all those risk factors that are present in the life of the veteran, and bringing them really to the point that we want them to be in, where they're leading healthy, productive lives and they're thriving in their communities. So.
And Kelly, how does outreach, or what you guys are sort of working on every day, differ between a place like Rochester or even Canandaigua, more of a city, than compared to rural places, Seneca County, Yates County, rural parts of Cuyahoga County, Wayne County, those types of places that people are thinking about when they think rural Finger Lakes? Obviously, you guys don't serve that entire area, but what is the approach, or how does the approach differ rural to urban?
Well, I think the big thing is with us participating in all the suicide prevention coalitions and all the 6 counties that we do serve, we're able to find out about different events. Our goal is to get out and meet veterans where they're at. So we go to sportsman's raffles, gun raffles, fire department things. You know, we get the Lilac Festival, as I mentioned earlier to you, that's in Rochester, but we go to the Out of the Darkness walks in all of the counties. We will go to parades and set up tables. Anywhere where we think we can get out to where the veteran is and meet them, because I realize that, especially in our rural communities, transportation is an issue a lot of times.
All the time.
All the time, yes. Even from one end of the lake to the other sometimes. Yeah. Transportation is an issue. So working with our community partners to really try and engage the veterans. We can't do it alone. And one of the VA's big things this year is really engaging the community and trying to not only raise awareness, but get to where our men and women who served are in their home communities. Let them know that we're here. Let them know that we can do, so they don't have to drive to Canandaigua or to Rochester clinics every day. We can do televideo. Mm-hmm. Just about every... I think I saw the statistics the other day where about 94% of all behavioral health employees now are able to do televideo with their clients, with their veterans, so that they can do it from a laptop. We have iPads we can give them. You can do it from your smartphone. We have our vital outreach team that will meet with people in schools through Vital, through the Veterans Integration to Academic Leadership Program, our TCM program, our Transition and Care Management for our newly returning veterans, goes out and meets with people. Our lead for that was actually just down with Dr. Kopacz in Livingston County 3 weeks ago, doing a presentation in conjunction with the coalition and in Livingston County, and trying to get people in there. So I think we're just... we always joke in suicide prevention team that I'll go anywhere and anywhere they'll let me come. Mm-hmm. We partner with the Legions a lot, the VFWs, AMVETS,
yeah,
schools.
It's interesting you mentioned the telehealth aspect of this, because we were talking about this before we came on, the rise of telehealth in general.
Yep.
And I want to get to both of you on this. Is that the future? Is that going to become, do you guys think, the main way that people interact with their health care, the people who are serving their health, moving forward 10, 15, 20 years? Obviously, I'm asking you to get the crystal ball out. And this is an off-the-cuff question, of course, but it's interesting, right? Like, especially, I would imagine, to the researcher, who's kind of trying to envision what this is going to look like eventually.
You want me to give it a shot?
Sure.
So, a very valid, very important question. Telehealth absolutely is the future. I mean, this is the direction our society is developing. I mean, it's at the risk of sounding overly poetic or philosophical, it really is the future. And with that being said, I would be of the school of thought that insofar as telehealth would and should be an option for not limited just to veterans. I mean, there are obvious benefits associated with telehealth, if only convenience, etc. However, I am of the school of thought that there's absolutely no substitute for a direct person-to-person interaction.
Right.
I would venture to say that in no point will telehealth ever substitute on an equal level the interaction that happens between a clinician and an individual meeting face-to-face. It's a whole different dynamic. You meet the person, not the person on a computer screen. And there's a lot to be said about that. And insofar as telehealth should be an option, I think the most important option of all should absolutely be the person-to-person interaction. Kelly, your thoughts?
Well, I would add on too that, I mean, usually even when we're doing the telehealth or televideo, VA Video Connect, as we call it, we still try to have a face-to-face at least once every couple months so that we do have that person, that human interaction. I mean,
Right.
So much of that has dwindled away over the years. That, yeah, telehealth is great, especially when there's transportation issues, but if we can still have those face-to-face partnerships and really develop that, then the video health or telehealth is a lot easier. Then you know the person on the other side. You're not just meeting
Right.
them through a video camera for the first time.
And when you're dealing with some of these rural communities, I would imagine that when some vets consider where they want to live and where they want to call home after service, some of these rural communities have appeal because it allows them to sort of get away from
Right.
the things, get away from people, get away. And does that sort of create a challenge for you guys, or is that where that challenge of, okay, how are we going to reach all of these people in these very small rural communities? Is that where that was sort of born?
I think some of it probably came out of there, and just recognizing that, yeah, we need to get to where they are. You know, and shy of building a clinic every 10 miles, you know, that is one of the easier ways to do that, and then maybe set up those face-to-face appointments maybe with all of their providers on one day. So it's one trip in to whichever city, Canandaigua or Rochester, that they're closest to get in for that face-to-face, but that they can still have their questions answered. You know, we have the capabilities where they can message into their providers through the VA too, in secure email messaging through My Healthy Vet. So that's another thing that they can always, if it's just a simple question and they don't need to maybe drive an hour to get for an appointment, they can send an email and have a question answered. They can have their prescriptions sometimes mailed to their home so that they don't have to drive in just to pick up a prescription and take all that time and deal with, you know, maybe paying for cab or Uber or Lyft or
Right.
however, but bugging family members to drive them. So I think, you know, we're trying any way we can. So
Worth also mentioning that the VA does also offer transportation options for veterans who are in rural communities. We will come and bring you to the medical center. We want to see you. You are a welcome guest at any VA medical center, and we'll do everything we can to bring you to where you need to be. And if, for whatever reason, there are certain mileage distance limits that have been set up in the Choice Act, I believe, that if a veteran is resident more than, I think, 50 miles or perhaps further from a VA medical center, they also have the choice of visiting a private healthcare provider as part of their VA benefits and services. So we absolutely are doing everything we can to ensure that every veteran who needs healthcare services has that opportunity to receive those healthcare services.
and the mileage actually will be lowering now with the new Mission Act that's coming out.
There you go.
So so those capabilities will be.
And it speaks to the easier access.
Yes.
You're encouraging better access.
Encouraging people to get connected. That's the big thing, is to get that connection.
And you're talking about that initial connection, not always that actual care connection. It just connecting with the VA first, and then
That's the big
developing
step.
that relationship so you guys can work more with them.
Yeah. I mean, I don't know how many times I go out on an outreach and I've had veterans say to me, oh, no, I don't need VA health care. I have good health care. And one of my favorite examples is, okay, so what about all the Kodak retirees who thought they had great health care and didn't register for their VA benefits that they earned and deserved, and now don't have health care? and now they're scrambling to get those things. And the other thing I always try to tell people is they say, well, I don't want to take money away from people who really need it. It's the exact opposite. The more veterans we get in, the more funding we get to help more veterans. So I try to, and then I have a lot of times vets will go, wow, really? I thought that was completely opposite. I mean, register now. Even if you don't need the services right away, down the road something happens and you do, you're already in the system. You're there. We don't have to go through, getting you registered. Not that it's a huge process. They can, you can register online actually, and then just bring in your discharge papers, your DD-214s to the Veteran Service Center one day and go from there.
But it is tied to funding for you guys.
Yeah. I mean,
Is that one of the challenging realities that you guys sort of have to deal with on a daily basis? Is that depending on how many people have actually connected with you up front in that initial interaction may determine whether you guys can provide all of the services ultimately that you want to provide to the vets?
I mean, I think there's, no matter what company or agency you work for, there's always funding questions. So, yeah, I mean, the more, like any business person would tell you, the more money we get, the more capabilities we have to help people, I guess is the only way
if I may
to put it,
chime in on that
yeah.
as well. Being on the research camp, the VA research camp, obviously research dollars, research funding is a huge deal for us, and it's validating and encouraging to know that, speaking of moral injury, the VA is devoting research dollars to researching moral injury. Taking that one step further, moral injury was actually named as a priority funding area for VA rehabilitation research. So it's nice to see that this problem is real, it's validated, that the higher ups are paying attention and devoting the necessary resources to letting us answer those hard-pressing questions of evidence-based strategies to help veterans. It will be very, very interesting to see what the future holds in that regards as well, the different research priorities and the funding dollars that are devoted to those priorities.
So when it comes to mental health and mental health awareness, one of the things that we hear a lot about is underreporting. When you hear underreporting, what comes to mind in your own application in terms of what you guys are doing on a daily basis and how it can sort of be combated?
Well, there's, I think, a couple different types of underreporting. There's sometimes where we don't get the information that someone has died by suicide. And there are times where people won't talk about it because there is still a stigma around mental health and around suicide. And we don't talk about that. That's that pink elephant over there in the room that we don't say anything about. The other side is that, especially with the opioid epidemic that we're hearing about, a lot of times we don't know for sure. So one of the things that the VA is starting actually this month is we're rolling out a whole new reporting system for our clinicians, that if they hear of someone who has either died by suicide or by an overdose, whether it's on medications or opioids or other substances, we are now starting to track all that through our national office, so that we'll have a suicide behavior and overdose report is what it's called, so that we can kind of get our pulse on that a little bit more. It's not going to tell us for sure that someone who died of an overdose for sure was a suicide attempt, but oftentimes we'll get information that it's like a death occurred and it's pending further investigation, and then we don't hear back again. In a local level. Right. There's the statistics are out there from national levels that they pull in the last one was 2016 because it was so much data to kind of go through from our national suicide prevention office to pull through all that. The ones that are known as suicide deaths, we get just a number. So trying to narrow that down a little bit more.
And I'm sure one of you can sort of speak to this. What do the numbers look like compared to the national trends of the total population among vets? What are sort of some of the trends in suicide and even on the awareness side over the last 10 to 15 to 20 years?
I mean, I think overall, we're relatively close to the general population. Veterans have a 67% higher rate of using firearms to take their life than the general population does. So that's one of the reasons that we have such a big push with firearms awareness. We hand out free gun locks for veterans and their families, or someone who knows a veteran, and they all have the crisis line information printed right on them. We're always trying to come up with different ways to keep like keys and things separate for firearms. But I mean, trending, you probably have more of the research data
Sure.
off the top of your head.
What we do know is based on the available data, we do know that veterans have, at least certain groups of veterans, have a increased risk of suicide relative to non-veterans in the general population. So we generally know that something's going on, and those rates, both among veterans as well as in the general population, have been increasing steadily for the past 10, 15 years. Would that be right, Kelly?
Yeah.
And so sum total, here now today, suicide is the 10th leading cause of death in the United States.
Yes.
The 10th leading cause of death. And just the incredible weight of that statistic is that you could prevent that. We can prevent that. Every suicide death is preventable. And part of that prevention strategy, and I know Kelly referenced really going into local communities, is asking the question. I can't stress that enough. If a pastor, a imam, a priest, a rabbi, be it in the faith community, or a teacher, a neighbor, suspects that someone close to them, a congregant, a neighbor, a friend, might be suffering, it's very good to ask that question. Are you thinking of hurting yourself? Are you thinking of suicide? And let me say here now, with full sense of responsibility, asking that question does not in any way, shape, or form stimulate the behavior. It does not plant a seed in anyone's mind. Quite the opposite. You have taken the initiative to open that door, to let the person feel comfortable enough to voice their thoughts, their concerns, that they might be suffering. And opening that door also opens the door to supportive services, to help options, because there is help out there. And I know we mentioned a second ago the idea of underreporting. It was an interesting research finding we got a few years ago that a lot of veterans, for whatever reason, might not voice suicidal thoughts, ideations during an intake assessment with their psychologist or social worker, despite being asked the question, but they will, for the first time, speak about suicide with a VA chaplain. So sometimes that VA chaplain is the first person who hears that Mr. Smith is thinking of hurting himself. And that chaplain then can get that ball rolling. Well, Mr. Smith, let's get you some help. Let's get you the help you need. Let's peel those onion layers and let's get to the heart of what's bothering you. Because again, every suicide death is preventable, and there is help out there.
And I will just say, just to piggyback on that, that even, I mean, the research has shown that asking that question in the most, I mean, trying to have it flow in the conversation a little bit, not, I have to ask you, those types of things, but coming right out and asking, are you thinking of hurting yourself? Have you had thoughts of taking your life? Has shown to be the most, had the most benefit, where people aren't wondering. I mean, I joke when I do some training sometimes where, you hear people say, well, do you feel like you're going to go see grandma soon and haven't? No, really coming out and asking that question doesn't leave any question about what you're asking about. And even if they're not having those thoughts now, a week from now, a month from now, a year from now, if they're having those thoughts, they may seek you out and say, hey, you remember when you asked me that question? Now I really need to talk to somebody. Like, I am starting to have some of those thoughts. Like, what do I do? Or, where do I go?
Okay, so I want to unpack this part a little bit, because I think that's interesting that you mentioned that. That's one of the things that we hear from a lot of folks in prevention in general, is that anybody can ask that question. Yep. Anybody can start that conversation. They can initiate it. Mm-hmm. my theory is that part of the reason why more folks don't do that is because it's really intimidating. And then what's
What do I
next?
do
The
next?
what's next? If the answer is yes, what on earth do I do next? And for the layperson, I think that's a really overwhelming responsibility to have
Fair
placed
enough.
on them.
Fair enough.
So I guess walk us through what those next steps are for that person who encounters that situation, maybe to disarm some of the concern that might be around it.
I mean, certainly if they're having very imminent thoughts where they have a plan and they've said or have, I always tell everybody all bets are off if they've taken any actions to harm their lives, take their own lives. If they've taken pills, they've started to cut anything that they've
Talking about and doing are two very different
talking about
things.
and doing. But one of the things that kind of throws up red flags is if they start to research ways to take their life, or they're getting what we call suicidal behaviors, and that isn't necessarily doing the actual act of trying to harm yourself, but it can be preparing your will, giving away your belongings, researching ways to die. How can I set up so my family's taken care of? Or, I know that after, I had a veteran one time, I know after this period of time, the clause is gone on my life insurance policy where my family will still get the benefit if I take my life after this many years. Okay, that's a big warning sign for us.
That's huge.
You can certainly always call the Veterans Crisis Line or text or chat with the Veterans Crisis Line, with the veteran there. They will want to talk to the veteran directly if they're willing to do that, or maybe on a speakerphone or however we can do that. If they're in imminent risk, walk them to an emergency room. Honestly.
Building on that also, if that imminent risk is there, exactly as Kelly mentioned, also you shouldn't be afraid to engage emergency services.
Right. Call 911.
Call 911. Call 911. For whatever inconvenience might be imposed on the individual, you will be saving a life.
Right.
And saving a life is obviously that much more valuable than whatever inconvenience they might be experiencing when you do call 911, when there is an emergency medical consultation or an involuntary hospital admission. But at the end of the day, you've saved a life.
Right.
And step one, before we wrap up here, throw all the resources at us, Kelly, where local veterans can go, veterans throughout the Finger Lakes, to take that step one, to just get connected with the VA if they are not already.
They can do it right online if that's easier for them. Some of our younger vets prefer to do things online. They can go right through the VA website to register through the VA benefits office, or walking into either the clinic at 465 Westfall or at 400 Fort Hill in Canandaigua. They can walk in and go right to the Veterans Service Center and talk with them. We usually tell them to bring their discharge papers with them. If they don't have copies of their discharge papers, they can request a copy of that through the National Archives. And that's, again, you can do that right online and request that right through there. It usually takes a little bit of time to get it. But oftentimes, even if they don't have their discharge papers, the Veterans Service Center has access to systems where there may be a copy in there.
Right.
And they can work with them to help do that request if need be. The other option, as I mentioned a minute ago, is calling the hotline. Any veteran from the counties that we serve, and there's a suicide prevention coordinator like me in every single VA across the nation and in every large community-based outpatient clinic. Every veteran that calls, texts, or chats the hotline and wants a follow-up gets a call back within 24 business hours from us. I don't care if you're trying to get registered, if you're having suicidal thoughts, if they had a rescue and we're following up at the hospital. It doesn't matter why you call. If you're in crisis, whatever that crisis is, and there's no judging, your crisis is your crisis, we follow up with you. So the hotline number is 1-800-273-8255. And if you press 1, you get to the Veteran and Military Crisis Line. For those that maybe aren't veterans listening, the 1-800-273-8255 is the National Suicide Prevention Hotline as well. When you press 1 is when you get to the Veteran and Military Crisis Line.
A point I'd like to make also about the crisis line is these are VA employees. You are connecting with a specific VA service. This is not an outsourced call center. You're speaking with VA employees VA clinicians, many of whom are themselves veterans.
Yes.
And this is, for a good chunk of callers to the crisis line, a first step into the VA system. They can help you overcome whatever hurdles, bureaucratic or otherwise, that are keeping you from getting your VA services. So if you're in the VA system or if you're not, this crisis line, 1-800-273-8255, press 1, really is for all veterans. And it's made by the VA for veterans. So I just like to make that specific point.
Absolutely. Appreciate the time, guys. Thanks for coming in.
Thank you so much.
Thank you.